Hello and welcome to the second module in this touching conversation activity. My name is Francesco Sclafani. I'm a consultant medical oncologist and I work at the Institut Jules Bordet in Brussels, Belgium. I'm really happy to be joined today by my esteemed colleague, Dr. Juan Manuel O'Connor, who is head of the Department of Gastrointestinal Tumor at the Alexander Fleming Institute in Buenos Aires, Argentina. Together, we will further explore biomarker-targeted approach to support precision medicine in the management of colorectal cancer. So, our first section is about biomarker-driven treatment sequencing in patients with colorectal cancer. So, making treatment decisions in colorectal cancer can be sometimes quite complex. It's important that we remember that we have to take into account a number of different factors. We have to consider, of course, patients' characteristics. We need to look at tumor biology, which means looking at certain clinical factors like, for instance, primary tumor location, so right versus left. And then, of course, there are some treatment factors, including a treatment goal. So, generally speaking, whenever we consider treatment for our patients with metastatic colorectal cancer, we consider in the first and second line setting a treatment which is based on standard chemotherapy plus the addition of a targeted therapy, either anti-EGFR monoclonal antibodies or bevacizumab. In the third line setting and beyond, we have now a number of different treatment options, with some also interesting emerging therapeutic choices like the anti-HER2 treatment. So it's great to have all these options available as treatment for our patients, but it's not always easy to define the optimal treatment sequence for our patients across the multiple lines of therapy. So Juan, let's take a look at some questions which were submitted by our audience on the role of biomarkers in treatment sequencing decisions in colorectal cancer. The first question is this: I'm interested in how to optimize the treatment sequence in my patients with colorectal cancer. For example, can biomarkers be used to guide treatment sequencing decisions? And does the use of a particular targeted therapy in the first line setting impact the choice of later lines of therapy?
This is a great question, Francesco. I think the best definition of how to decide our treatment for our patients is based on the patient characteristics and also tumor-specific biomarkers. So it's not only the biomarker, the RAS testing or the MMR. For sure, it's an important piece of information for defining the first line treatment, but also important to know what is the clinical condition of our patient, performance status, wishes for our patient. And I would say that we have the good news is that we have many options, but the question now for the GI oncology or the oncology in general is how to define the best sequence for our patient. And I would say that probably for the future, it is important to know more clinical evidence in terms of the strategy. A followed by B is the same or better than B followed by A, for example, in terms of the strategy. Probably this is the most important thing, or the most important question to answer for the future for our patient.
Thank you, Juan. We have got another interesting questions from the audience, which is the following. Have a patient with MSI-high advanced colorectal cancer harboring a RAS mutation. They initially responded to first-line immunotherapy, but their disease is now progressing. How would you approach such cases in your clinical practice? Do you decide on second-line treatment based on the biomarker status?
This is a different setting, Francesco. I think that it's probably the new kids on the block. this kind of patient, MSI high patient, and how to treat them after the immunotherapy. For sure, after the response rate and also control of the disease with immunotherapy, for this kind of population, I would say it is important to know the RAS mutation in terms of the second or later line for our patient. Let me add something about some probably a different point of view for this kind of patient, for example, Francesco, in terms of the NTRK fusion, for example, because this is a hypermutated tumor. So please, just to remind you that for this patient, there's some resistant mechanism of the disease. Maybe it's a fusion genes. I would say it's a rare resistant, but probably more frequent in this type of patient with MSI high, mainly the patient with RAS wild type, non-Lynch syndrome. I would say this is probably some differences when I discuss the option after progressive disease with MSI high patient, different to the microsatellite stable disease with colon cancer and advanced disease. And for sure, I would like to know your opinion, Francesco, and if you have some experience in how to treat patients after progressive disease with MSI high colon cancer.
First of all, I have to say that I personally tried to stop immunotherapy as late as possible. So I tried to foresee if the patient is possibly having what we call the pseudo-progression before considering the patients as resistant to immunotherapy. But of course, at some point, when it's clear that the patient is actually progressing to immunotherapy, then we don't have any other choice than changing treatment. But of course, if we don't happen to find these biomarkers, then I suppose what I do in clinical practice is I consider these patients as being, let's say, treatment naive. So basically, I treat them with standard chemotherapy plus targeted agents, where the targeted agents would be either anti-EGFR monoclonal antibody or bevacizumab, depending on tumor sidedness and RAS-BRAF status. Okay, let's now move to section 2 of this module and talk about practical challenge in biomarker-targeted treatment of colorectal cancer. So there are a number of potential challenges when treating patients with colorectal cancer. So there are some challenges which concern patients. So we know that not all patients are the same, and there could be some patients who may not be well educated regarding treatment options. They may not be aware about what to expect actually in terms of both efficacy and safety and toxicity from those treatments. Then, of course, there are other challenges that we have to face in our everyday work. And these are, I would say, different type of challenges. So these are more, let's say, organizational or institutional challenge. We know that sometimes we might struggle, for instance, to have access to certain techniques and novel technologies, for instance, a liquid biopsy. And then finally, it's always important to remember that even if we are very well supported by our pathologists, molecular biologists, as clinicians, we have to learn how to best interpret the molecular report, for instance, coming from our lab. We have to remember that even if we give the best treatment to our patients after an accurate molecular selection, this treatment may still not work because of the complexity of the tumor and the tumor microenvironment, the tumor heterogeneity. So these are all challenges that we have to keep in mind in our everyday practice. So Juan, let's now take again a look at some of the questions that were submitted by our audience. So the first questions that we have got is the following. When I am exploring biomarker-targeted treatment options with patients, what are the One of their biggest concerns is about the safety and how much their quality of life might be affected. Can you share your thoughts on how to counsel patients about potential side effects? What additional support do you provide to patients in terms of side effects management?
I think that the very important point in terms of the quality of life, the objective of the treatment, it is different in the first or second line compared with the later line. So I think that we are, just to clarify for a patient, is the response rate, try to decide what's the objective of the treatment, and also clear communication with our patient in terms of how is I expected in terms of the results with the treatment. Is a response rate, is a control of the disease, for example, and I would say the quality of life are included as a secondary endpoint in many clinical trials after progressive disease in second or third line on later lines. And also the other important thing is in terms of toxicity, monitoring our patient closely, and just to educate in terms of how is the most frequent adverse events in terms of the target therapy. But just I would to learn from the clinical studies and also the real world study, how is the best approach for our patient to try to avoid the serious adverse events, mainly for the targeted therapy and also for immunotherapy. And let me add something, Francesco. I think that the telemedicine is another good tool for control our patient. I think that was one of the best tool after pandemic situation. As you know, I think that it's great to contact our patient, but telemedicine because it's more easy in many cases.
All right. So now we have got another questions from the audience, which is the following. How would you like to know more about how to approach the challenge of efficacy variation, whereby different patients respond very differently to a particular biomarker-targeted therapy? How do you tailor treatment selection and individualize monitoring to address this issue in your own practice? And is there a way to make monitoring and follow-up less burdensome for patients?
Well, the personalized precision medicine to identify the best patient with the right treatment is in terms of the biomarker, but there are some primary resistance and also secondary resistance. So it's important to clarify for our patient and also understand what is the implication of some response rate, and also after long time of some time of treatment, the secondary resistance to the first or the second line treatment. But for sure, the use of the biomarker is the best option. But it's not only the biomarker, it's the patient characteristic, as I mentioned before, the clinical condition, the sidedness is another important topic, and reducing the toxicity, and also monitoring the treatment option every 2 or 3 months, for example. It is important because if the treatment it doesn't work, probably it's more important to change and avoid some toxicity with not useful treatment, and also monitoring treatment in order to discover the primary resistance or secondary resistance and avoid toxicity for our patient, Francesco.
So now we move to the last section of this module, where we will be talking about emerging targeted therapy for patients with metastatic colorectal cancer. So, as we discussed already, we have a number of different biomarkers that we use in routine practice, and these biomarkers can be actually targeted with a number of compounds that are already approved for routine use. But it's very important to note that there are a number of other compounds which are being investigated in different stages of clinical research, so from phase 1 to phase 3 clinical trials. And these compounds include monoclonal antibodies, small molecule, antibody drug conjugate, vaccine, immune checkpoint inhibitors, and other molecules which can possibly provide additional hope to our patients. So let's take again a look at some questions submitted by our audience regarding emerging targeted therapies for patients with colorectal cancer. I find that keeping up to date with the latest research and developments in the field of colorectal cancer can be very challenging. In your opinion, what are the most interesting emerging colorectal cancer therapies in development that oncologists should be aware of? And how do you think they will affect the future prospect for patients?
Great question, Francesco. I think one of the probably most important combination is a new immunotherapy combination, as you know, the botensilimab and balstilimab. That was a combination of immunotherapy, anti-PD-1, and new generation of anti-CTLA-4, just for microsatellite stable disease. That is the key point. So this is the phase 1b and shows the very promising activity in terms of response rate. For sure, we need to more validation. And now it's ongoing the phase 3 trial based on the, I think, the NEST 1 trial that was presented last year. So new combination based on the immunotherapy and also some anti-angiogenics, for example. I think that there are probably a subgroup of patients that can benefit from this combination for, again, microsatellite stable disease, such as nivo-regorafenib or pembrolizumab. And also, Francesco, HER2, new combination in HER2, data coming from the refractory disease, but very good response rate and median PFS for refractory disease in HER2 positive, just amplification or mutation, and a new combination for the future. And now ongoing open the phase 3 trial Muntaner with the looking for the benefit or the efficacy of the chemo plus anti-HER2 versus chemotherapy as a standard of care. So it's very curious to know for the future how's the best strategy for our patient.
So now I suppose we have the last question from the audience. Are there any emerging indications for targeted therapies on the horizon in colorectal cancer? For instance, is there a potential role for these therapies in the neoadjuvant setting? Could this play a role in novel management strategies such as organ sparing?
Yeah, interesting. I think, Francesco, that if we have the biomarker, why not to testing in a more early disease? That's, this is the question, and probably different setting to the advanced disease. And now we have more data, and I'd say you probably remember when this data was presented in ASCO last year in terms of the result of the dostarlimab anti-PD-1 for patients with rectal cancer and MSI-high patient. That was very impressive result in a phase 2 trial after the first 16 patients, including 100% of clinical complete remission. So just to keep in mind what's the impact of this result in terms of avoid toxicity for our patient, no radiotherapy, no surgical approach based on this very promising data, and also sustain for very long time the impact of the treatment and just with immunotherapy as a neoadjuvant treatment. So the question now is the surgery necessary for our patient in this subtype of patient, MSI-high rectal cancer? And also there are some data looking for the role of the targeted therapy or the biological agent based on some clinical characteristics for the patient. The Foxtrot was a very important trial. Just looking for the new concept to give the treatment before the surgical approach and for a better condition, clinical condition for our patient, and the primary endpoint of the residual or recurrent disease within 2 years that occur less frequent in a patient with neoadjuvant chemotherapy versus the control arm. So I think the concept is important. For sure, we need to more data in terms of the biomarker for this population in localized disease, in terms of validate how is the role of the neoadjuvant chemotherapy plus minus biological agent for this population.
Great. Thanks so much, Juan, for all these great insight that you have provided us. And I thank you, the audience, for watching us. I really hope you enjoyed this activity. And bye for now.